One common concern is when trying to achieve pregnancy, if I don't get that first pregnancy test within a month or two, what is going on? What are the possibilities? What things can I potentially modify? Or if I've had a miscarriage, was the miscarriage caused by my disease or was it a natural state? One of the key things is really disease control is important in reducing inflammation, which also improves pregnancy outcomes. But I think it's also important to recognize that up to 1/3 of miscarriages are natural miscarriages. In other words, those would have happened in women who have no disease state whatsoever. And so the key is not to become discouraged when a miscarriage does occur, but control the factors that you can. And that's usually the way I discuss it with patients, is that we try to maximize disease control in order to improve the likelihood of conception. There are other things women can focus on, such as timed intercourse around the time of ovulation can assist as well. We know that women, when they get past 30 years of age, may have a decrease in the natural fertility they may have had prior to 30 years of age. And so as a result, if a person doesn't conceive after 6 months of regular intercourse, attempted timed intercourse for pregnancy, they might even consider reaching out to a reproductive endocrinologist who can assist with evaluation to see if there are other factors that should potentially be considered in achieving pregnancy. So when planning a pregnancy, certainly one of the focuses of the mother is I want to have the healthiest pregnancy possible. And if you think about a lot of the counseling we focus on is things like avoid alcohol, avoid smoking, and the mother begins to focus on, are there any things that I'm taking or exposing my baby to potentially inside that I can minimize during pregnancy? The important portion of this we like to point out to patients is that a healthy mother is how we achieve a healthy pregnancy. So both are very, very important. And when we look at autoimmune disease, keeping that mother under control, keeping her autoimmune disease in remission is very important in achieving that optimal pregnancy outcome. So when we look at that, we look at medications that can be used. And believe it or not, what a lot of people don't realize is the majority of medications used to treat autoimmune disease, especially with relative to bowel disease, that sort of thing, can be used safely in pregnancy. So many women in this day are currently being managed, for instance, on biologic therapy. And biologic therapy is aimed at different aspects of suppression of the immune system, and many of those being TNF-alpha inhibitors that they may be using, such as adalimumab or infliximab being the most common and most studied across pregnancy, being very effective at suppressing and keeping autoimmune disease in remission. Certolizumab is also an option in the anti-TNF-alpha group, which has a very specific property that it doesn't cross the placenta effectively. It does not have the ability to cross the placenta even to the baby. So we have these discussions with women in a group-based setting, meaning that you ideally need a group of physicians who you're working with. So you come to the table usually with a GI specialist who has been managing your condition. You then meet with a maternal fetal medicine specialist like myself, where we then begin to really focus on what has been the course of your disease over time, how has it affected your life, have you had surgeries in the past, have there been the possibility of needing even diversion surgeries like a J-pouch or an ileal conduit for some of these women, have they had other complications that may be present. And then we focus on medication therapy that has worked and has not worked for them, with a focus on reducing steroids. And I think that's really important, and that's where the anti-TNF-alpha agents have really helped us, is that we can often reduce those steroids to none. And so we can remove steroids from the table and keep them on those medications throughout pregnancy, and even beyond that. You know, you think about the course of care, even into breastfeeding, postpartum, you know, and ongoing care. So when we're thinking about a woman of reproductive age, I think one of the key features is beginning to think the average woman in America will have slightly more than 2 children, between 2 and 3 children. And so in knowing that, and also in knowing that pregnancy is not always planned, it is a good idea to begin thinking about that process, even at the GI perspective, at the gastroenterologist who's evaluating that patient who is of reproductive age and making decisions about medication use that would be safe. There are some medications we don't recommend. For instance, methotrexate is a good example, which is used in autoimmune disease, especially for treatment of Crohn's and ulcerative colitis. For that medication, for instance, we recommend that a woman be off of that for at least 3 to 6 months before she becomes pregnant. And so there's a good idea to come off of some medications. Tocilizumab is another medication that's recommended to be avoided in the first trimester. So that's a medication that if a woman were to be started on either of those two, I think it's important that she also know to talk to her physician as soon as she recognizes she's pregnant so they can make appropriate plans for transitioning if that is the best medication for control of her disease.